substance abuse issues in the home. In my whole section there that we're talking with them, I'll ask them at any point in your childhood or adulthood, have you ever been subjected to any type of abuse? And it's very common that patients will say yes, and they don't want to elaborate. And I don't make them elaborate. I'll ask them the next question if they say yes. And I'll tell them, I don't expect you to elaborate, but I just need to know, have you ever sought any therapy or counseling for that? And it's very common that most of them will say no. And so for 20, 30, 40, 60 years, these people have been carrying baggage of some traumatic event that happened at 3, 4, 5 years old. And they're still in that grieving process. They're still in denial, they're still angry, and they're still bargaining through what happened. And we're trying to deal with a set of chronic pain issues in someone that has a whole undertow of other things that have happened. So that initial history and dealing with that cognitive perception side is very important, because pain has multiple levels, and pain is not just the perception of a noxious stimuli now, is it? The aspect of psychological pain is very real. So one of the best direct-to-consumer marketing commercials ever made, and I can't remember who it was. See, I can't remember the drug name, but the commercial said, depression hurts, which is true. If we look at the diagnostic criteria in the Diagnostic and Statistical Manual for the diagnosis of mood disorders, somatic complaints are very high on the list. So they may have disrupted or fragmented sleep, but they're going to oftentimes complain of pain. And so we know that there is a pain triad or a pain triangle. And if there's one thing you can remember from this, you can forget everything else I've said in this lecture. I want you to write down, I want you to figure out a way to type on your little computers, because we didn't have these whenever I went to school. We were still using a pencil and paper. But you're gonna write down the pain triad. Okay? We have pain, we have mood, and we have sleep. Do I need to draw it up here? Somebody did a pretty example up here. I've got bad writing. We have pain, we have mood, and we have sleep. We're going to get back together, whether you all like it or not, because I want to hear about your experience and who else is going to Dark Brooks, because I'm going tomorrow. In 2 weeks, I'm going to be back and we're going to talk about this here. But this is important. Why is that? Because if I'm in pain, I don't sleep well. I have disrupted, fragmented sleep, correct? If I'm in pain, I'm grumpy, I'm tense, I'm irritable, I'm working through that whole breathing process. But if I'm not sleeping well, we know that if I deprive you of enough rapid eye movement sleep, I can employ full psychotic behavior. So I know that sleep is absolutely paramount to how we function on a daily basis with mood. But I also know that there are certain aspects of sleep that we'll talk about later that are involved in our healing process, in the anti-inflammatory process. So it's absolutely paramount that sleep be achieved such that we can help to modulate this. And then on the other side though, I know if I'm grumpy, tense, irritable, this will make my pain worse. We know that patients with mood disorders that are untreated commonly use more opiate medications, their pain scores are rated higher, and their daily dysfunction when it comes to activity of daily living is much higher because of their mood component. But we also know mood plays a significant role in sleep. Okay? So one of the classic signs and symptoms that you're going to find with your first patient that you diagnose with a major depressive disorder is they will tell you they're not going to use these terms, but you're going to figure out that they have early morning awakening or arousal with complete inability to return to sleep. How many of you all have been worried about the exam, and I wake up at 3 a.m. and I can't go back to sleep because my brain is activated. Or you broke up with your high school sweetheart and we started waking up at 2 or 3 in the morning and we just couldn't go back to sleep. Well, that's because these two interact with one another significantly. So when we think about treating pain, you can't just deal with this, now can you? We're going to talk about this next time, but that's very important. And we've already talked about how important this is. So in my opinion, if we look at the pain triad, if you look at the pain triangle in published data, this is how they'll put it. But really what it needs to be is it needs to be rotated. Because unless we deal with the mood side, it doesn't matter what we do with all of the rest of the interventions, we're not going to get to where we need to be at truly treating where the patient stands with their pain condition, whether it be acute, chronic, or acute on chronic. Okay? Any questions up to this point? We're an hour in. You guys need a break? I mean, I got 3 girls, so when I travel, they got to pee like every 30 minutes. So, pee? Okay, go.